Good morning, everyone. Today I'm going to present about my master's thesis on the impact of modulation, high modulation on delivery accuracy for treatment modalities such as IMRT and VMAT. So briefly, it's implementing a modulation complexity score or a metric for both the treatment plans at Sir Charles Gordon Hospital. So it was supervised by Pejman, Rowshan, Farzad, and Sivakumar Somangili. Thank you. So as an introduction, I'd like to go over some of the basic things, such as the treatment modalities available for cancer. There are, as you already know of, there are various modalities including external beam radiotherapy, chemotherapy, surgery, immunotherapy, and so on. However, we'll be focusing on external beam radiotherapy. Among them, IMRT and VMAT are quite novel and which are currently in most use in clinical practice. The reasons is just because of its conformal dose distribution, organ surface sparing, less than interfraction and interfraction variability, and so on. And also it gives, in a dosimetric point of view, it is quick and efficient for people, and also it gives comfort for them and reduce the late toxicities in terms of QA process. So these are some pretty pictures I took just for dose distribution comparison between all the older one, which is three-dimensional conformal radiotherapy, and the newer ones, IMRT and VMAT. Just briefly summarizing, intensity modulation radiotherapy is achieved through segmentation and in each beams and setting a number of beams around the patient to spread the dose in the patient. There are two basic types of intensity modulated radiotherapy, step and shoot and sliding window methods, which is usually static mode and dynamic mode in the LINAC. So step and shoot usually uses around 3 to 9 beams around the patient treatment volume, and then in terms of comparison, sliding windows use more segments compared to step and shoot, and goes around the patient. So yeah, it delivers continuously while the fields are reshaped in the beam. That's the basic difference between them. So volumetric modulator arc therapy is an evolution from IMRT, sliding window method. The gantry rotates while the beam is delivered, similar to IMRT sliding window method. However, the intensity is modulated through control points, various control points around the beam. So as we already know of, it's delivered through LINAC. So there are various parameters. While we focus on collimator system, we use two collimator systems, primary and secondary. Primary is the traditional method used for square and rectangular fields, which is just 4 blocks of lead. In terms of secondary, it's modulation multi-leaf collimator. It's just tungsten leaves, smaller tungsten leaves driven by miniature motors. Usually we can find around 40 to 120 leaves. For this project we used the MLC 120, HG 120 variant. There are some advantages and disadvantages for MLC, which is such as confirmed field. In terms of disadvantages, there are like interleaf leakage, penumbra, and some. It's basically due to the mechanical and geometrical instabilities and stuff. Delivery accuracy. So the primary aim of this project, determination of impact of high modulation on the treatments are verified by various literature such as McNevin and Massey. Actually, they were the base for this project because they created some complexity metrics which we used in this project. they also informed that the modulations are mainly due to the varying MLCs, gantry, angles, geometric and dosimetric limitations, and there are some other parameters as well. So for IMRT treatments, the parameters are leaf variability, segment area variability, and the monitor units. In terms of VMAT, along with them, the gantry speed variability, dose rate variability, and collimator angles are also the reasons behind the modulation. There is always a trade-off between modulation and the complexity. Modulation and the treatment outcome. Say, for example, comparison, 3D CRT had lesser complexity, with just square or rectangular fields, however, but poor conformality and poor treatment outcome, whereas for IMRT and VMAT had higher complexity due to variable changes during the treatment, but better conformality. Complexity can affect delivery, can be due to delivery inaccuracies, can lead to delivery inaccuracies, and affect the treatment as a whole. Maintenance assurance of the plant so quality assurance is in part in all these treatments, just to make sure everything goes well. That's just a basic summary of definition of quality assurance, maintenance assurance of the plant systematic service to be successful. There are various QA processes in radiotherapy, such as LINAC QA, dosimetric QA. For every specific part of the treatment, there is a QA process, which is suggested by the international organizations such as AAPM. Pre-treatment QA is done by the dose verification system, such as diode array or EPID. Relatively speaking, in treatment planning, the dose is modeled. The steps of the treatment planning, such as the dose is modeled by TPS, then the dose is delivered to a 2D or 3D array for dose verification from the expected and the delivered outcome, which is compared as in 3 different criteria as gamma index analysis, 3 or 4 different criteria. However, this diode arrays has been recently replaced by EPIDs, and in terms of our project, most of the plants were delivered in EPIDs. Gamma index analysis was introduced by Low et al. In 1998, which is basically the measure of quantification of dose difference between predicted and measured values, and it is measured in terms of dose differences and also distance to dose agreements. The pass rates of above 95% is acceptable in terms of clinical practice, which is the same used in Charles Gordon Hospital still. So related literature reviews has been done, such as the McNevin or Massey, who introduced the modulation complexity metric. So McNevin introduced MCS for IMRT, Massey introduced for VMAT. It's simply a quantitative analysis of complexity in the treatment, of a treatment, in terms of giving it a score from 0 to 1. So if a treatment comes as a 0, then it's has the highest complexity. If it's 1, it's least complexity. In terms of MLC, you can assume that, like, if there is a completely open MLC, then it's 1. If it's closed or if it's narrow, the segments are narrow, then it will be close to 0. However, for this for our project, we changed the complexity from 1 to 0. 1 to 0 because it will be more applicable, like 0 being the less complex and 1 being the most complex. They've also found positive correlation between modulation complexity and the gamma pass rate. As we can see, it's a significantly moderate correlation, 0.5 and 0.54 for the 3% 3 mil and 2% 2 mil. And also they suggested that it's a possible candidate for complexity metric in those treatments, and also it helps QA and workflow as well. Other studies have evolved this metric into multi-institutional comparison, dose comparison, and also for dosimetric audits. So, such as Rajshekharan and Megari, which have done the similar studies. They have also proved significant correlation between MCS and gamma pass rate, which our study has also concluded. We have used a data called TG119, which is a test suite for mock clinical research defined by AAPM, and also it's used for commissioning of IMRT treatments in terms of multi-institutional comparison, dosimetric comparison. The primary aims of the projects are implementation of modulation complexity metric for the IMRT and VMAT plans, and also establish the relationship between the complexity metric to the gamma pass rates, gamma index analysis. From there we can estimate a threshold for each site-specific treatments. Like say for breast, there will be like the complexity will be within this range or with this value of specificity and so on. So for materials and methods, we use the DICOM-RT plan files. So DICOM-RT structure is basically includes image, plan, structure, and those files, which were used in various parts of the treatment planning. Among them, RT plan file is essentially consists of the treatment plan itself, which consists of the beams and the plan parameters, and also the patient information as well. So just to make it as an analogy, a treasure map analogy for the DICOM information extracted. So initially we have the plan we get into the plan parameters, and then from there beam sequence consists of the beam type and the treatment machine information, which then leads to the control point sequence, which has all the beam energy and the monitor unit proportions and so on, which then leads to beam limiting device position sequence, such as the MLC positions and so on. So using those MLC positions and the JAR positions extracted, we calculate the MCS, three parameters of the MCS, which will be detailed in soon. And also we use the monitor units from the fraction group sequence, and also the beam dose for dosimetric comparison. So eventually come at the big modulation complexity score for the beams, individual beams, and also for the arcs. So the parameters we calculate are leaf segment variability, aperture area variability, and monitor unit relative segment weight. So it can be summarized as positional variability between adjacent leaves in a segment, in a bank, relative to the maximum possible change in the same bank in the segment. So we have to do this for each banks and also for each segments in a plan, in a beam. So simply speaking, more narrow and the more irregular the segment shape is, then the larger the score will be. In terms of aperture area variability, it's just the area accounts for between the MLC positions opposing leaves. So aperture variability in a single control point normalized to the maximum aperture for each leaf pair in all the segments. So the maximum apertures for the whole for all the beams, all the segments in the beam. So yeah, that also same. If the segments are more, if the segments are beams consisting of maximum aperture relates to the largest score. So the relative segment weight is also incorporated, which is primarily used as a complexity metric in most clinical practice, which if simply higher the MU monitor units, higher the larger the score. So these are the formulae we used for the calculation for IMRT and VMAT. Pretty much both of them are closely the same. However, there are minor differences in terms of monitor units extraction, because the dose is delivered rapidly in terms of VMAT. So we used MATLAB and for the script and the formula of extracted from the literature. So and also the plans we use for the verification, dosimetric verification, are from Sir Charles Gardner Hospital. There were like totally 100 plans. However, we had extra plans, which some of them weren't having some overlap between the plans already taken. So these are the pass rates for each treatment site, along with each criteria defined. We just summarized as a mean value for comparison. The models used were variant true beam, and the MLCs used for variant HT 120, and most of the plans had the EPID gamma verification. So for results, summarizing everything in a few plots, modulation complexity score for all different treatment sites has been summarized. Say, for example, prostate or head and neck. It's on the same order. And we can see that both the IMRT and VMAT plans of the TG files have higher complexity compared with the other scores. And also, just explaining that for these two treatments, so these are the TG 109, which had like 4 IMRT and VMAT plans. In terms of we had another 7 phantoms, which were found to be found to be more complex. So among them, 3 of them are IMRT and 4 of them are VMAT plans, and they are of different treatment sites, like phase, parotid, or and so on. As you can see, the IMRT plans had the highest complexity, probably because could be due to their number of beams and also their segment shapes. However, the most plans fall within the range of 0.5 to 0.9, with the 95% of the plans falling below 0.8. Prostate, head and neck, and prostate and the head and neck plans are falling with a similar threshold. Could be due to the fact that prostate plans, we had a wide range of prostate plans, which is 54. However, for head and neck, we just had 10 plans, so could be due to that. And found that brain plans were relatively complex in terms of site-specific comparison. However, the IMRT plans have outweighed both the head and neck and also the TG 109 VMAT plans. Probably could be due to the high number of beams and also due to the smaller segments, and also it had a higher, significantly higher monitor units as well. For gamma pass rate comparison, as we already could expect, the IMRT plans had less pass rates compared to the other plans, and also the brain plan also had lesser pass rate compared to the other plan as well. And there are some failed plans which we included in the study as well. However, we couldn't find more failed plans. We just included around 5 failed plans, which have shown in this pass rates. These are in agreement with the IMRT plans for MCs, and also the phantom plans didn't show much complexity in MCS. However, they had a relatively low gamma pass rate. Probably the failed plans are the reason for the skewness of the plot as well. Comparing the monitor units for each for all the treatment sites, as we already assumed, like the patient-specific plans, the treatment site-specific plans fall in the range of 400 to 800. However, the other TG plans and the phantom plans, which we found established to be complex, fall outside the range of that. And yeah, the IMRT plans had correspondingly relatively high monitor units, around 1,000, above 800 monitor units, which is high for any plan. So these are some data analysis which we done, and there are some confidence intervals for each site-specific analysis. So this for the prostate plans, 54 prostate plans, we included the MCS values found to be 0.6 and 0.668, which is relatively complex, not as complex as other plans. And also the monitor units is significantly low compared with other plans as well. And then we calculated the time for each plans, the calculation time, the script calculation, which is just 1 or 2 seconds for all the plans except for the IMRT and VMAT plans. And a Pearson correlation analysis has also been done for verification of relationship between complexity and gamma pass rates, and we found a significant correlation between MCS and gamma pass rate for prostate plans, and also we plotted them for a linear regression analysis as well. Probably to define a threshold, we need more failed plans to define a range for threshold values for each site-specific analysis. And we can establish that with this number of plans which are sufficient enough compared with other studies, we can establish that MCS is moderately correlated with the GBR. In terms of brain, we had 21 plans, and we had a confidence interval similar to the prostate. This also took around similar time as well in terms of calculation time. The hypothesis testing also found that there are significant relationship between MCS and gamma pass rate for different criteria, which can be again summarized by this plot. So this plot is to establish the monitor units and gamma pass rate relationship, which we found to be significant enough. And also there seems to be significant relationship between MCS and gamma pass rate in terms of brain as well. We can establish that. For other plans such as head and neck, we didn't seem to have much of a correlation, which could be due to the lesser number of plans, which is just 10. And also in other plans such as the VMAT plans from the TG109 and also the IMRT plans, they all had a relatively low value or less significance in comparison. So in summary, we can establish that we can expect for at least a weak to moderate correlation between MCS and gamma pass rate. And also the data set we had could be significant enough to establish this relationship. However, we found in comparison with other studies, we found significantly lesser gamma pass rates could be due to the improvement in treatment outcome in Charles Gordon Hospital, because the other studies had also been done quite early, like 2010 and 2011. And the LINACs used are also quite new in terms of performance and also the QA has also been improved a lot in these recent years. This could help planners in assisting for before a pre-treatment QA for gamma analysis. They could get a basic understanding of how the plan is going to be, like a deliverability of the plan, and also the complexity of the plan to be known. This could be also extended for multi-institutional analysis and osmotic audits, which is done in other studies, and also we could compare with different LINAC manufacturers, which has also been done by other studies, which showed significantly higher correlation for variant LINACs compared with Electa or any other LINACs. And also we can compare it with for TPS as well, different TPS. This could also be extended for, there are multiple various complexity metrics available, which can be accumulated and then can be used for machine learning application, just treat the planning. In conclusion, Modulation Complexity Score, a metric has been established, and also its relationship has been verified. So if we establish in the clinical setting, say for example in Charles Gardner, the planning quality and the QA as a whole will be improved, and also can save treatment planning time for planners if we could implement a threshold value for each sites. These are some of the references I use. My deepest thanks to everyone involved. Everyone supported me and assisted me throughout this project, especially Pejman, Rowshan, Farzad, Sivakumar, Marco, Masheed, Zaid, Godfrey, Tom, Talat, Monair, and also the whole medical physics research group for especially, and also Charles Gardner Hospital for allowing me to take their plans and doing the analysis. Thank you. Thank you so much.
Really great.
Thank you.
So the complexity, we obviously need more complex plans for certain situations. So what are the things that make us want to use a more complex plan? What is it about the patient and their disease that makes us want to use a more complex plan?
So right now we use treatment planning for we compare both the IMRT and VMAT setup for a site, and mostly we establish a treatment for site like say for prostate mostly via VMAT, and we proceed. But if the plan is found to be more complex, we can optimize the plan for, like, say we can even optimize this in the same treatment setup, or we can even change it to a IMRT or VMAT setup, I guess. Is that the question?
Groups, like the brain group,
Yeah,
for example,
yeah.
There's a variation in complexity
Yeah,
in that group.
yeah.
Why would one patient's plan require more complexity to another patient's plan? What might drive
That could be due to the size and the shape of the cancer in each patient, and also the planning. It has been done with the segments and the leaf shapes being analyzed by the planning system. Could be due to that, I guess.
So you're assessing plan deliverability by relating the MCS to the gamma pass rate.
Yeah.
So can you think of any limitations of using the gamma pass rate to assess like the plan to begin with?
Could you please repeat the question again?
Yeah,
Sorry.
So you're relying on the gamma pass rate to assess your plan being delivered correctly.
Yeah.
Are there any limitations of the gamma metric?
Yeah, that's for sure, because in most plans we used were EPID-based verification, and most of the EPID-based verification has found to be significantly higher pass rates in comparison with the traditional dose 3D or 2D arrays we use, diode arrays we use. So yeah, it significantly reduced the gamma pass rate range for each plans, probably because of the sensitivity of EPID and improvements in the QA, I guess. Did that answer the question?
Kind of.
That's
Basically, like for the gamma tolerances,
yeah.
for example, whether the errors that the gamma picks up are necessarily clinically relevant or purely geometrical.
Yeah. I'm not sure.
That's okay. Yeah.
Sorry, I'm not sure.
Okay, from Zoom, any questions? Kat?
Yeah, I had one, Prince, if that's okay.
Sure, yeah, sure.
With your failed treatment plans, what do you reckon? Was there like one main cause behind the failures? Or one cause that had the most influence?
Actually, could be due to the segment variability and also the monitor units, but the failure is mainly due to the I guess the comparison. Yeah, I'm not sure actually, because we haven't looked into the plans, how the dose structure and the plan the complex how do you say the tumor structure and other parameters. We just looked into the plan parameters, the beam parameters, which we use for the planning. So I'm not sure the reason for the treatment failure. Could be due to those parameters as well, like the dosimetric parameters such as the MLC positions and stuff. But
I just wondered if there was a way you could reduce your number of failures. That's all. But
Yeah.
Thanks. Good talk. Thanks.
Thank you.
Any other questions from Zoom? No? Happy? Thanks everyone.